everyone. Today I want to share my research about the treatment of condyloma accumula caused by low-risk human papillomavirus with chloroquine phosphate gel. I will introduce my presentation from the following aspects. First, I will introduce introduction of the chloroquine. Second, I will explain the development process of chloroquine phosphate dosage form. The next one is about the effect of CQ gel on DA models that are caused by low-risk HPV. And the fourth one is some toxicology experiments of CQ gel that we tried. The final section is the conclusion of the presentation and the prospects for CQ gel. Okay, let's see what is the chloroquine. As we all know that chloroquine is four aminoclines with two phosphate molecules, and currently there are 23 CQ products on the market in China, including 22 chloroquine phosphate tablets and 1 injection. CQ tablets are usually used in YVAX malaria, inhibition and prevention of malaria, preventary, and also usually they use for rheumatoid arthritis and other diseases. So after the outbreak of COVID-19 in 2016, CQ was recommended as one of the antiviral drugs by the National Health Commission of the People's Republic of China. Since then, there are more and more research reports on CQ against the viruses, including CQ against the human immunodeficiency virus, HIV, and the influenza virus, Zika virus, and Ebola virus. However, about HPV, there are also so many reports that illustrated CQ can significantly reduce the occurrence time of anal cancer caused by high-risk HPV 16 by inducing authority. In addition, there are some researchers reported that blood clots caused by low-risk HPV basically disappeared after oral administration of CQ for 1 to 3 weeks. So, based on this report and also the experimental data from our previous cooperator laboratory, we decided to develop CQ for anti-HPV infection. However, the disease caused by HPV usually occurs locally, but the existing CQ tablet and the injection are not convenient to use. Therefore, we decided to develop a new formulation for CQ for infection skin and the cervix. So first, we tried to make chloroquine to a suppository. For the first figures here, we use the gelatin as the shaping agent. It's easy to get the gelatin, but it's difficult for us to dissolve the gelatin during the progress of the product. Next, we tried the PEG as the shaping agent. Now it's easy for us to dissolve the PEG as the shaping agent. But the problem we faced is that the PEG suppository will be melt easily when the temperature is higher than 30 degrees. Especially in the summer, it will be difficult for us to keep it. So we tried another prescription to make the chloroquine gels and the cream. And finally, during a long period, we got 2 products of CQ gel and also one CQ suppository. Because it's easy for the suppository to melt, so we decided to develop CQ gel first. After that, we did the assessment of the stability of the CQ gels from 1 month to 24 months. And every 3 months, we test the pH and viscosity, content uniformity, and the content of the CQ gel. From 1 month to 24 months, there's a little changes of all these parameters. So that means that the CQ gel is stable for use in the future. Okay, after we get the stability gel, we want to know if the gel really has the effect on HPV induced disease. So we tried to build a CA animal model. We transplanted the disease site of a CA patient to back to the pack of a nude mouse. After 14 days, we want to make sure if there is still some cited cells here. So we did the HE stain to check. We found that the kelocyte cells were observed in the slime. So that means the CA model was successful to use in the ventral test. So begin the formal test. We chose the 40 nude mouse, half male and half female, to create the CA model. After the model built, 3 doses of CQ gel were given to each group of the CA model. And after 14 days, we used the CQ gel on the surface of the CA tissues. We found that the walls in all the groups with CQ gels will become smaller, and no new walls grew up when compared with the control group. Also, we tested the body weight of the nude mouse. We found that no obvious abnormalities in the body weight of the animals in the different group of the mice during the experiment. But the wall weight of the gel groups were all reduced after giving the chloroquine gel for 14 days. Okay, if the weight of the walls were changed then how about the HPV DNA content in the tissues? So after that, we use the PCR to detect the DNA copies in the wall tissues. So as shown in this table here, we will see that after given, no matter it's low doses gel or medium or high doses, the DNA copies of HPV6 and HPV11 were all reduced after giving the chloroquine gel for 14 days, especially the medium doses. It reduced significantly. Also, we did the HE stain to check the color cells in the slime. Compared with the control group, we will see that there are still some kelocytes in the low doses group and the middle dosage group. But in the high dosage group, there's a smaller amount of kilo size here. But we will see that even there's a smaller amount of the kilo size, excuse me, there's still even the necrosis of the wall epithelial cells were increased. This indicates that the CQ0 were irritating to the skin to a certain degree, and as the doses increased, the irritation becomes greater. We will see from those low degree, middle degree, and high degrees here. Also, we also use the immunohistory to analyze the expression of p53 protein in the wall tissues in the different groups. So compare with the control group, the positive stain of p53 in the walls was significantly enhanced as the doses of the skin doses of the CQ increased. So that shows dose-dependent relationship between p53 protein expression and the CQ. So based on this result of the experiment, we get that so far we got stable. The CQ0 was stable for 24 months, and it can reduce the weight and the DNA contained in the CA tissue. But the CQ0 was irritating to the skin for a certain degree. As we all know that there are many adverse drug reactions that may occur when used CQ, especially because we use the CQ gel for the outside use. But CQ can induce skin itching, rash, and irritability. If the CQ gel was irritating to the skin too much, then it will be limited the use of the CQ gel on skin and in vagina. So next, we selected New Zealand rabbits to observe the skin irritation of CQ from two aspects of destroyed skin and healthy skin. And meanwhile, we use the genopics to test the hypersensitive test to see the CQ gel really has the irritation and how degree it will be induced the irritation. So after giving 4 days of the CQ gel, we found that the CQ gel was safe for 14 days on the healthy skin. But if it used on the destroyed skin for a long time, maybe more than 10 days, it may cause more obviously skin irritations and will prolong the healing process of damaged skin and may explain the scope of the damage. So totally, in the summary of my presentation, we got a stable CQ gel and it has the effect on CA, but there is no irritation to the healthy skin, but there is a certain irritation to the damaged skin, and it will delay the wound healing. So as we all know that after infection with HPV, it generally takes a long time to have symptoms of the disease. Although HPV screening and vaccine injection are good ways to prevent HPV infection, there are still a large number of people infected with HPV. CQ is very promising for the elimination of HPV in the infection period, but how to efficiently eliminate and avoid adverse reactions caused by long-term medicine should be the focus of for the further attention. So here is some references for this PowerPoint presentation. And thank you so much for attention. This is the end of my presentation.
Dear colleagues, my report is devoted to the use of allogeneic cartilage grafts in nasal reconstruction. Current concept of nasal reconstruction includes separated reestablishment of all layers of nasal tissue. We have to cover skin defect using skin flap of adequate size and design. Inner nasal lining can be formed using intranasal mucosal flaps or additional turn-in skin flaps or fascial flaps. We have to provide stable nasal construction using support structures. Cartilage grafts of patient's body, ear or rib, cadaver cartilage, and artificial meshes are traditional materials to create nasal support. All materials are characterized with some advantages and disadvantages. For example, autologous cartilage size is limited. Dystrophic changes of cartilage can be present in elder patients. Harvest of autologous material are associated with significant additional trauma. Also, artificial materials are more expensive and they present unnatural mechanical properties. Also, they aren't available for each patient. I have to mark most patients with acquired nasal defects in Eastern Europe are elder patients with skin carcinoma and comorbidities. It looks use of allogeneic cartilage can be defined as near optimal solution in those patients. Some skepticism to allogenic cartilage can be explained with low number of studies, and the next question should be answered to prove its safety and long-term stability. Is allogenic cartilage graft associated with complication? Does allogenic cartilage provide acceptable outcome? Does allogenic cartilage retain long-term stability? We present our experience of use of allogenic cartilage grafts for nasal reconstruction. There were 73 nasal reconstruction performed. Demographic data are present on the slide. Most of patients were cancer patients of high age. All operations were performed in oncology and otorhinolaryngology clinics, Gomel City, Belarus, Central Europe. Most defects involved 2 or 3 subunits of nasal skin and subdermal layers of external nose. There were so-called complex nasal defects. There are standard patients with secondary defects or native look of nasal skin carcinoma. There are samples of post-resection nasal defects in our patients. We evaluated complication rate, need of unplanned correction, and cosmetic results after reconstructions. Cosmetic outcome was scored separately by patients and experts using 5-point scale in 6 months or more after reconstruction. This slide presents insertion of allogenic cartilage grafts and non-anatomical grafting was used to provide stable construction of reestablished nasal alar. Total number of complications was 9. It took out about 12%. 3 cases of wound dehiscence and 3 cases of partial flat necrosis were developed, and 2 complications probably were related with inserted cartilage. It was wound dehiscence and next cartilage graft extrusion, and one more case forming of abscess at the site of cartilage area. So total rate of complications associated with allogeneic cartilage graft was near 3. All complications developed in patients with risk factors. Most common complications are presented on this slide: partial flat necrosis and wound dehiscence. Distribution of patient scores of cosmetic outcome is present on this table. Patients mostly scored nasal appearance with optimal or suboptimal scores. And lower scores were reported in nasal alar, nasal dorsum, and nostril size indicators. Expert scores were mostly lower than patient scores, and nasal alar and nostril size were scored with lower scores. Comparison of patient and expert scores shows a statistically significant difference for indicators: nasal alar, nostril size, nasal skin color, nasal position, and total nasal appearance. Unplanned correction was indicated following 10 reconstruction. However, 4 patients gave up revision procedures, and in the next 6 cases, delayed correction allowed to improve total nasal appearance. This slide presents patient with poor outcome. Left photo, significant displacement of nasal alar is present, and right photo, patient presents secondary defect of central part of nose after forming of abscess at the area of reconstruction. Excellent outcome, 5 points by expert and patient. This patient after reconstruction of subtotal external nose defect. Moderate outcome by expert and good outcome by patient. In patient with reconstruction of nasal through defect after development of late posteradiative ulcer. Good outcome in patient after reconstruction of subtotal nasal defect, 4 points by both patient and experts. Ultrasound and MRI of re-established nose was performed in 12 patients to evaluate stability of inserted cartilage in 2 years or more after reconstruction. Ultrasound scan is present on this slide, and it presents comparison of allogeneic cartilage road left and intact side cartilage road right. Both cartilage present same size, same thickness, and same echoicity. No significant deformity and size loss is present. Hypoechoic area of at the site of surgical suture is road, but we compare it with the native cartilage mass presenting homogeneous echoicity and clear border. No blood flow inside the cartilage graft is discovered, and it means that the blood vessels didn't penetrate within cartilage mass. Slight blood flow is present at the area of surgical suture left side of row. MRI of re-established nose with allogeneic cartilage is present on this slide. Both cartilage present stable position, no size loss. They are covered with thin fibrotic capsule and doesn't present significant lesions of tissue. Okay, we got specimens of nasal tissue containing allogenic cartilage parts, and morphology presents fibrotic capsule around the cartilage with a clear border. Cell dystrophy is present in both cartilage specimens, but no matrix lesions is present in both examined cartilages. So we can conclude that complication rate associated with allogenic cartilage was comparable low, less than 3%. Acceptable cosmetic result of total nasal appearance was achieved in near 90% of cases. It's comparable with reported studies and ultrasound examination and magnetic resonance examination of nasal tissue revealed cartilage allograft stability in all examined patients following minimally 2 years after completed reconstruction. Thank you very much for your attention.
Hi everyone, I'm Dr. Pakinam Nabil. I'm an associate professor at Cairo University in Egypt. So our case was about a case of erythromelalgia that has been diagnosed after a lot of work. The patient had an orthopedic surgery on his right arm. So being a rare condition, I would like just to give you a little bit of a reminder about erythromelalgia with the updates that knowledge has come through. So I'll just start with the history of erythromelalgia that was first described by Dr. Mitchell in 1872 and was called Mitchell's disease. And then in 1892 was described further by a pediatrician, Dr. Gerard, and was named Gerard's disease. And in 1964, it was described secondary to myeloproliferative disorder. And then in 1990, Drenth and Michels from Netherlands named the secondary form as erythromelalgia. However, for other causes, it was named as primary and secondary erythromelalgia. Recently, vascular and neural dysfunction have been described for primary and secondary forms. In 2004, erythromelalgia is the first human disease with sodium channel mutation and chronic neuropathic pain. Next, please. So, erythromelalgia is a rare acrosyndrome affecting the extremities with erythema, swelling, pain, which can be either episodic or continuous. It comes from the Greek origin, erythros, which means redness, and melos is limbs, and algos is pain. It can be complicated by fissures, ulcers, cyanosis, gangrene, infections from water immersion. Next, please. Next, please. It has been described with criteria, diagnostic criteria suggestion by Calgard and Marks as burning pain of the extremities, erythema, increased temperature, which improves with cooling and worsens with warming. Next, please. Unfortunately, because of the difficulty in its diagnosis that comes to mind to physician, the median months to diagnosis would be up to 24 months. Next, please. So it can be either primary, which is the idiopathic type, or secondary to toxins, infections, surgery, myeloproliferative disorders, or drugs. It can be either early or present late in adults. It can be associated with acrocyanosis or Reynolds in 15%. Next. So drugs causing erythromelalgia, just the ones that we commonly report, are simvastatin, bromocriptine, COVID-19 vaccines, calcium channel blockers, and some diseases like lupus, diabetes, and rheumatoid arthritis. Next. Differential diagnosis, as you can see, is a wide list. However, we're gonna sum them up to the main conditions with peripheral pain, erythema, and edema. Next, please. So, We have, for example, next please, reflex sympathetic dystrophy, which is peripheral pain, swelling, hyperhidrosis, which is called complex regional pain syndrome, which is triggered by tissue injury, and the MRI shows gray matter structure and atrophy of the subcutaneous fat pads of the hands. Raynaud's, which can be primary or secondary disease or phenomena. The neural injury can be excluded by nerve conduction studies. Compartment syndrome can be excluded by Doppler. Lymphatic or venous obstruction, which is just swelling, and still Doppler can help. Next, please. The pathophysiology is either neural or vascular. The vascular is due to acute vasodilatation with microcirculatory flow 10 folds and temperature increases by 7 degrees, and unfortunately capillaroscopy does not help. While the neural is due to a mutation in sodium channels with hyperexcitability of the receptors, release of histamine, serotonin, prostaglandins, bradykinin, substance P, calcitonin gene-related peptide with C fiber dysfunction and spontaneous activity, resulting in dorsal root ganglion stimulation, hence brain stimulation of putamen, insula, and cingulate. Next. So the brain response has been proved by the functional MRI, where the cooling effect on the limbs showed the pattern of reward pleasure, like pain stopping. Recently, they are both interconnected, as you can see. Next. Next, please. So how are they interconnected? Authors have mentioned that the primary dysfunction is of the small fibers, resulting in impaired microcirculation and hypoxia. Vascular distribution can lead to hypoxia and hence triggering the neuropathy, which is the case in secondary erythromelalgia. Next. The sweat glands show anhidrosis or hypohidrosis. So, the autonomic dysfunction has been proved in various studies as decreased the density of the catecholamine nerve fibers, abnormal autonomic reflex with a postganglionic sympathetic function, autonomic dysfunction in MS patients and in seminoma patients. Next, please. And there has been a proof of small fiber neuropathy as proved by evoked laser potential, cold and warm detection thresholds, electrochemical conductance. Next, please. And the mutation of sodium channels has been proved to be a gain of function mutation, which might be either spontaneous or inherited, as hyperpolarization or decrease in activation. Thus, it affects the clinical picture. So the decreased in activation, the slow inactivation is a mild disease. However, the hyperpolarization shows an early onset, like those appearing in children. Next, please. This study studied the MRI changes in patients with erythromelalgia, where during the pain, there are changes in the MRI. With the cooling effect, it calmed down. Next, please. So, how can investigations help us to diagnose a patient of erythromelalgia? Unfortunately, skin biopsy shows decreased nerve fiber density in the skin, which doesn't help much. The nerve conduction studies are normal. The capillaroscopy, as we mentioned earlier, is normal. Next, please. So, what did we do with our patient? He was a 61-year-old male patient with marked erythema, pain, warmth, swelling of the upper 2/3 of the right arm, presented in short sleeves on a winter night. So imagine a patient coming on a cold winter night with short sleeves. And this was the clinical picture of the patient. You see the swelling, the redness, and you see he folded his sleeve up. It's a short sleeve. Next, please. So orthopedics checked that there's no abnormality regarding the surgery, nor the technique, nor the infection. Nothing. There was nothing wrong. It was a standard operation with plates and screws. Next, please. So after exclusion of the differential diagnosis, as we have mentioned, of peripheral pain, erythema, and redness and pain, it came to our mind that this is an atypical case of erythromelalgia. So I started the patient on diltiazem 60 milligram once a day, and then increased to twice a day. The swelling resolved to normal, the redness almost disappeared, and the swelling decreased by 2 centimeters in diameter after 1 month of treatment. The patient came back after 1 month in long sleeves, which shows that the heat or the increased temperature that he felt was gone. Next, please. As we can see, this is the before, the picture above, and this is the after picture with the swelling markedly reduced as obvious in the picture. Next, please. So, treating erythromelalgia after genetic testing has shifting from vasoactive drugs to anti-neuropathic medications. The primary erythromelalgia is better treated with sodium channel blockers like lidocaine. The secondary erythromelalgia can be treated by managing the underlying cause and understanding the mechanism. If it's more towards the neural or if it's more towards the vasoactive or vascular component. For example, like our patient, our patient's case was published as a clinical letter in the German Journal of Dermatology. It was a post-surgical vasospasm where calcium channel blockers successfully relieved the case. However, I've mentioned in the causes as secondary erythromelalgia, calcium channel blocker can be actually a cause of secondary erythromelalgia. So, to our surprise, our case was like a trial and error, and this made us understand better the underlying mechanism in our case. Next, please. So, we have to educate the patient to avoid excessive warming, to avoid water or ice immersion. As we can see, patients who immersed their limbs, they had so many complications with fissures, ulcers, and up to gangrene in some case studies. Drugs can be used. We have to keep our mind open to aspirin, prostaglandins, antidepressants, sodium channel blockers, calcium channel blockers, anticonvulsants, immune suppressives, antihistamines. We have to keep all this in mind while treating a patient of erythromelalgia and understand really the underlying mechanism, especially in secondary cases. Next, please. So, I'm just reminding you that the pathophysiology is either neural or vascular or can be interconnected. Next. Treatment can be topical or systemic, as we have mentioned. Some studies mention that steroids can help. Others mention that steroids doesn't help. So we reached the conclusion that steroids has like a golden window, okay? But however, studies haven't settled on what is the golden window. They haven't settled on this part. Next, please. So what's new? We have spinal cord stimulation, dorsal root ganglion stimulation, chemical sympathectomy with phenol, epidural infusion, behavioral therapy to stop immersion in water and ice, amitriptyline and ketamine topically, Botox injection, and this is very interesting and can be helpful to patients as it's accessible to all dermatologists in clinics. Steroids, as I mentioned, has a golden window. Anti-inflammatory can be better than neuromodulators with low neural density even. Next, please. In the in the JAD, Journal of American Academy of Dermatology, in 2022, they mentioned a possible algorithm that we can use to help us treat the patients with erythromelalgia, being a very difficult and tricky case. First, patient education, of course, and we can add the mixilitine, which is a controlling drug, and we can start at 200 milligrams per day. And if it persists, we can increase by 100 to 200 milligrams per day with a maximum of 600 milligrams per day or 20 milligrams per kg per day. If the pain persists after 2 days, we can add the carbamazepine. If the patient had acute attacks, we can add rizatriptan. If the pain after the mixilitine does not persist, then we can just treat the acute attacks and we don't add the carbamazepine. And if no acute attacks happening, then we do not use the rizatriptan. Next, please. The controversial parts, as we mentioned, the calcium channel blockers, the carbamazepine, the amitriptyline, sympathetic block for short-term, oral opioids have shown limited benefit, however, have been mentioned by some studies. Next, please. So our take-home message is that primary erythromelalgia, think of neuromodulation. The secondary, according to the underlying disease and proper understanding of it's either neural or vascular or interconnected, we can use the neuromodulation, the vasoactive drugs, and the anti-inflammatory. Erythromelalgia has a great impact on patients' life. It's underdiagnosed. As we mentioned, it can take the patient 24 months till it's diagnosed. It has to be in the differential diagnosis of peripheral edema and pain, and treatment options have shifted to neuromodulation and anti-inflammatory medication. It's still trial and error. However, understanding the underlying mechanism will help us choose the best for our patients. Thank you.
Hello, dear colleagues. The diagnosis of a skin disease is based largely on its morphology, both external and cell morphology in the pathological focus. Dermatologists don't have many laboratory tests that help diagnose a patient with a skin disease. The main diagnostic tools of a dermatologist are his eyes and hands. Often a dermatologist finds it difficult to diagnose due to an atypical clinical picture of a skin disease, changes in the clinical picture due to inadequate self-treatment by the patient, a rare skin disease, and other reasons. Modern diagnostic methods such as dermatoscopy and histological examination of biopsy material come to the rescue. Dermatoscopy is a non-invasive and affordable method of diagnosing skin disease. Helps in the differential diagnosis of skin neoplasms. Sometimes it's necessary to look at the neoplasm in more detail in order to accurately diagnose it. In Russia, dermatoscopy and biopsy sampling are included in the professional standard of a dermatologist. All doctors should be able to perform these procedures. This slide presents two elements that are clinically similar. Both patients complained of dark color element. Clinically, the formations are represented by nodule of a dark color with clear boundaries with a flat surface. But the dermatoscopic picture is different. In the first case, it's a structureless area of blue color, it's blue nevus. In the second case, vascular lacunas is hemangioma. We'll also differentiate these elements with melanoma. It's not always possible to make a diagnosis even using dermatoscopy. There are two patients of the oncology clinic on this slide, a man of 60 years old and a young man of 23 years old. In both patients, the elements are represented by nodes protruding above the skin with a bumpy surface. The dermatoscopic pattern is also very similar. There are black color, hyperkeratosis, chrysolite type structures. After surgical removal and histological examination, basal cell carcinoma and melanoma were found. In more difficult clinical cases, histological examination of the biopsy material helps us. Biopsy is a method that allows us to determine the exact cellular composition of a skin fragment, to investigate pathohistological processes in a pathological focus. It's used when other non-invasive methods don't give an accurately result. Depending on the method of sampling, the following types of biopsy are distinguished. Excision biopsy is a biopsy of the entire removed formation. This is a technique that consists in the complete surgical removal of a pathological lesion or tumor and its subsequent histological examination. Excision biopsy is performed on nevi, genital warts, malignant skin formations such as melanoma and other skin neoplasms. Incisional biopsy is the sampling and examination of a fragment of a pathological lesion or neoplasms. It's used for extensive lesion in terms of area and depth. Complete removal of the lesion doesn't occur, but a fragment is taken with a scalpel, razor, and an electrocoagulator loop and sent to laboratory for histological examination. Aspiration biopsy is an examination of the aspirate of the tissue under study using an ordinary syringe. This slide is present difficult clinical cases in which biopsy material had to be collected. Hypertrophic form of lichen planus, hidradenitis, anatoderma, actinic cheilitis, diarrheoid disease, psoriasis, combination of villus and hypertrophic forms of lichen planus, lupus erythematosus. In order to take away all the layers of the skin in the pathological focus, it's better to use the method of punch biopsy. Punch biopsy material sampling using a special tool, dermopunch. The main advantage of the method is that a column of skin is taken in which there are fragments of the epidermis, dermis, and subcutaneous fat. The tools that are used for the procedure are dermopunch, tweezers with thin branches, scissors with thin tips that fit snugly together. Dermopunch is a sterile instrument. Tweezers and scissors must be made of steel without plastic parts because they will be disinfected and sterilized. The punch biopsy procedure is shown in the video.
I want to show the procedure, dermopunch procedure, and for this procedure I need cotton pads, skin antiseptic, container with fixator, dermopunch, and scissors and tweezers with thin branches. This instrument, these tools are sterile, and my patient needs anesthesia, and I'll do it. Так, все хорошо, сейчас чуть-чуть потерпеть. Все, укольчик. Оп. It's ultrakind under skin, and we need to wait for 5 minutes for anesthesia. I'm checking our anesthesia. Я уколола. Что скажете?
Ну, я чуть-чуть чувствую, но...
Чуть, но очень далеко, да?
Ну, там
Или
критично
практически не было. Patient said it doesn't hurt. So и теперь прямо вот эту процедуру снимаем. Вот там на коже. I'm scrolling derma punch with pressure. Анечка, что, чувствуется, нет?
Чувствуется.
Терпится? Угу. Плотненькая, тут инфильтрат. I made this circle part of the skin. And I'm pulling up and cutting off this fragment of the skin. And I am putting this fragment into container with fixator. Сейчас, минутку. Fixator is formalin. That's all. So.
After the procedure, the wound heals within 7-10 days, during which time the patient uses antiseptic and regenerating drugs. This slide shows a child, 7 years old, with a permanent skin process from 2 months. The child was diagnosed with vulgar pemphigus, and this child received methotrexate from 2 months old. The child's mother turned to the Department of Dermatology of our university. During the inspection, we found erosions and pustules. There are no pustules with vulgar pemphigus. A histological examination was performed, after which the diagnosis of Sneddon-Wilcoxon disease was made, in which dapsone can be prescribed. The drug dapsone is safer than methotrexate. Punch biopsy can also be used for differential diagnosis of clinically similar skin disease. For example, eczema of the hands, psoriasis of the palms and soles, Diverges disease, or Diverges disease, the follicular form of lichen planus, shiny lichen, or when the diagnosis is completely unclear. This slide shows a patient with such a clinical and dermatoscopic picture, which don't provide clear date for diagnosis. Histologists have given the answer: it's parapsoriasis. Thank you for your attention. Thank you.
So, good morning, everybody, from here, from El Salvador, and good night over there. To me, it's a pleasure to be participating in this amazing webinar. I want to share that I'm a BYE third in dermatology, the first generation of dermatology in my country. I want to start talking about multiple papular lesions in a photoexposed areas in a healthy elderly female patient. So I want to start with you sharing this amazing picture from my country, the capital city, San Salvador. I think there is an amazing photo that we can discuss even more. We want to start for the identification of our patient. This is a female patient with 79 years old from La Libertad, San Salvador, near from the capital city. It's a 79-year-old female patient previously healthy who consulted for a disseminated dermatosis in the B-zone of the neckline and forearm and leg on the anterior faces. This is important because we're gonna discuss about the pathologies that occurs in this patient. This dermatosis was consistent of multiple well-defined raised papules of warty appearance, keratotic at touch and some yellowish and other grayish-white, most of them with an erythematose base. The larger one was 0.3 millimeter and the smaller one was 0.1 millimeters. These are the clinical images of our patient of the anterior B-zone of the neckline, posterior thorax, the legs, and these are more upcoming picture of the patient. So the rest of the skins and annex of the skin was not contributory findings, and we made some hypotheses of the diagnostic from keratotic equine ostial and dermal duct nevus or Davier's disease or keratosis of Mibelli. The patient consulted with a 2 years history of lesion initially on the legs and 11 months fever. Of the consultation, they spread to the trunk and forearms. It was self-medicated with a combined cream usually used in this kind of patient in our country that is uh, sell in pharmacy with it's called betamethasone, clotrimazole, and gentamicin. It was put on demand and he was not seeing any improvement. On dermoscopy, we see a lesion with a huge disorganization in architecture and pattern that suggests biopsy. It shows a non-melanocytic lesion with arborescent vessels and light brown structure with filiform distribution pattern, yellowish punctating structure covered with a white scale on the surface. We initially take the plan to treat this patient with 5 millimeter punch biopsy, a thin that soaks usually in the daily base, and usually a body cream, usually 3 times a day. We take 2 biopsy. The first one was on the anterior thorax that show us a moderate and to severe orthokeratosic, hyperkeratosic, and epidermal atrophy with papillomatosis formation on the dermis and mild superficial perivascular lymphocytic infiltrated inflammatory that it was compatible with stuccokeratosis. This is a more images of the first biopsy. And the second biopsy was taken on the right leg that shows the same things that we saw in the first biopsy with infiltrated predominantly of lymphocytic, compatible with stuccokeratosis. So we came for the final diagnosis of stuccokeratosis. Stuccokeratosis, well, I want to share is another picture of one of the famous beaches on our country that is called El Tunco Beach. That it actually is a more world famous because surfers from all around the world came to participate in surfer competition here. Talking about stuccokeratosis was once described by Coxar and Offner in 1965. It's a rare benign process characterized by the appearance of warty, keratotic, and millimetric papules, usually asymptomatic. It covered with a grayish white color on the upper and lower extremities. It's also known and in the literature known as a keratosis alba. This is more frequent in older male patients with a ratio of 4 in 1, but this case is interesting because this was a female patient. The prevalence of this stuccokeratosis is the 7 to 20%. Sabat considered there is a type of keratosis separate together with dermatosis papulosa nigrans, and stuccokeratosis is one of the different clinical presentations. Is often known is a pathology of unknown and unknown etiology and describes a possible association with human papillomavirus. In this study, Hafner shown that there was um, a mutation with a wild type of FR3 genes that is shown in 5 patients with stuccokeratosis. It was shown that the mutation was in the very up lesion of the dermatoses, and it also suggests that a possible involvement of a lifetime ultraviolet exposure. Most common lesion was in fair skin patient, and it is associated with UV light UVA1 exposure. On the histopathology, we show that the patient showed pigmentation, acanthosis, hyperkeratosis, and papillomatosis. The only thing that wasn't there in our biopsy was horns. On dermoscopy, usually shown as a network-like structure, sharp demarcation areas, media-like cysts, mold-eaten borders, fingerprint structure, fissure, and comedon-like opening. In our patient, we only showed network-like structure, sharp demarcation borders, and also shown as a finding in this patient a hairpin blood vessels. We can take the different diagnoses on stuccokeratosis of seborrheic keratosis, epidermal dysplasia verruciformis, Darvier disease, and acrokeratosis verruciform of FOP. Treatment is also usually indicated in this patient. Sadly, the patient recently passed away, and we wasn't able to indicate a good treatment. But if we can treat the patient, we will treat it in salicylic acid at 5% twice a day, retinoic acid at night, tricloracetic acid or 5-fluorouracil cream, isotretinoin, and electrocoagulation if the lesions are really in one region of the patient. This is a possible association with esophageal cancer considering the stuccokeratosis as part of the lesser prelat sign based on the positivity of EGFR that actually this patient died recently because of um, stomach cancer. I want to thank my super doctor, Doctora Guevara Cerritos, dermatologist from National Hospital from El Salvador, Doctora Alexandra Maza de Franco, dermatopathologist from El Salvador. I want to end this conversation sharing you this amazing picture we took yesterday where you can see all the staff and medical residents of our national committee in Central America National Hospital of Sacramento. Thank you.
Thank you so much, Doctor. That was an excellent presentation. Would anyone like to ask any questions? If you do, you can drop it at the chat box, or you can
Hi, this is Dr. Basilio. Good morning. I thank to the organizing committee of the event for the invitation to this interesting virtual congress to learn from colleges and masters from other countries. And this is my turn to share my experience with the case of a patient who comes to my office due to alopecia, which is a scar type alopecia. And I must comment that our initial diagnosis was not Langerhans histiocytosis, since this condition, as you know, is more common in pediatric age, and it was revealing when the comprehensive diagnostic approach was carried out. I have not conflicts of interest. I only mentioned the dermatoscopes that I usually use in my daily practice, in addition to the photo finder. And this is the case of a 36 years old male patient, farmer, originally a resident from Tecalitlan, Jalisco, Mexico. He came to my office due to diffuse alopecia, accompanied by numerous scabs, purulent and seromatic discharge, and more than 10 years of evolution, and intermittent, and exacerbated 2 months ago. He had received multiple previous treatments that include oil, sebum regulators, antibiotics, and topical ointments, and medium potency corticosteroids. Physical examination revealed this disseminated dermatoses affecting the entire scalp, consisting of plaques of scarring, alopecia, that alternate with erythematous scaly plaques. The pool test was positive. You can see here the absence or follicular osteum and the area where I took the punch biopsy. In the facial region, numerous papules, predominantly frontal and at the center of the face, erythematous, some skin color, flesh color are in the upper extremities, the distal third. We can see these papules that convert to form erythematous scaly plaques, total nail dystrophy, and xanthonychia. As we can see here, whitish and atrophy in the axillary area. As an important background, the patient has cognitive and psychomotor deficit and simple partial seizures. The patient also was receiving magnesium valproate and had a surgery for a rib fracture at 24 years old. Here we can see this timeline, the most important clinical manifestation that the patient tells us during the interrogation until the day that he visited us. At the 8 years old, the patient has seborrheic dermatitis of the golden face, axillary, and inguinal candidosis. Then at 15 years old, seborrheic dermatitis become more intense with remission, exacerbation symptoms. Then at the 24 years old, the patient had a surgery due to a non-specific rib fracture. At the 32 years old, rash on extremities, nail dystrophy, and a biopsy result in dyskeratosis, disease, barrier disease. At 35 years, scalp, cervical, and extremity pain, intense itching, and friable skin lesions. And now, with the trichoscopic examination, we can see vascular spots, yellowish and bloody crusts, whitish, yellowish perifollicular structures here, and white lesions, which is very suggestive of fibrosis and cicatricial alopecia. These areas tend to form a nebuloid pattern as well at the lower pole of the photograph. The hair with different diameters, absence of the follicular osteum. And about the histopathology study, the section stained with hematoxylin and eosin with a proliferation in the superficial and middle dermis, a proliferation of mononuclear and some binucleated with an oval and round nucleus, and some reniform appearance, broad eosinophilic diffuse cytoplasm with edematous stroma. This is here a very dense inflammatory lymphocytic and eosinophilic infiltration. The morphology of the cells were of histiocytosis. We decided to perform immunochemistry markers, CD1 and CD100. Both were positive. Therefore, we considered the diagnosis of Langerhans histiocytosis. Now, this is a turn then to the approach, an integral approach of a multidisciplinary team. So we refer to a hematologist and oncologist to perform a cranial tomography, radiography, and finally, we found bone multifocal disease. This is classified as a single system multifocal langerhans cells histiocytosis. Then the patient received 4 chemotherapy cycles of cladribine and prednisone, but then we have relapse and sepsis, and unfortunately, the patient died 6 months after the initial diagnosis. Let's talk about Langerhans cell histiocytosis, a brief review. The Langerhans cells are intraepidermal dendritic cells whose main role is antigen presentation to effector T cells. They are located in the suprabasal layer in the epidermis and dermis. Typically, these cells have dendritic process which extend between the keratinocytes and toward the epidermal junction, a labellated nucleus and a clear cytoplasm where the characters Birbeck granules, the racket inclusion, as you remember, in ultrastructural finding in this cell by electronic microscope. And the Langerhans histiocytosis is a disorder characterized by the clonal proliferation of the cells of the mononuclear phagocyte system. This is a very interesting diapositive. We can see the development, distribution, and principal main function of these cells. Plasmacytoid dendritic cells originate in bone marrow from myeloid-committed progenitors and dendritic cells population that can be found in the intestine, skin, bone marrow, from myeloid-committed progenitors. And this picture, we can see the main functions, the pathogen killing, antigen presentation, with the associated molecular cell, MHC1, MHC2, tissue repair and wound healing. The antigen process. In this picture, we can see the physiologic Langerhans cells and dermal dendritic cells ontogeny and function. Under normal conditions, Langerhans cells precursors arise from yolk sacs progenitors or fetal liver monocytes that seed the epidermis and are maintained locally by radioresistant epidermal Langerhans cells precursor in the steady state. Circulating dendritic cells restrict precursors are constantly recruited to the skin to replenish dermal dendritic cells. And during injury or inflammation, bone marrow-derived monocytes can differentiate into epidermal CD207 positive Langerhans-like cells or dermal dendritic cells like that replenish the damaged Langerhans cells and dermal pool of dendritic cells. According to this model, the stage of differentiation in which the myeloid cells acquires activating MAPK mutations determines the extent of Langerhans cells. So the high-risk multisystem Langerhans cell histiocytosis arises from self-renewing stem or progenitor cells from bone marrow, and the low-risk multisystem Langerhans histiocytosis arises from MAPK activation of committed dendritic cells precursors or monocytes. And low-risk single lesion arises from a regional dendritic cell. And finally, the MAPK activated precursor cells, as we can see here, contributes to the formation of Langerhans cell histiocytosis lesion through the following mechanism. The enhanced myeloid differentiation, impaired migration, the apoptosis, inhibition, and inflammation. In this diapo, we can see the activation of MAPK pathway mutation. So we see in the 8 growth factor, the tyrosinase kinase, then the leads to activation of RAS, then activation of RAF, then the MEG, and then this kinase. This kinase is an extracellular signal regulate kinase, the ERK. This leads to activating mutation such as BRAF, the BRAF V600E. The BRAF V600E is a 64% mutation showed in the Langerhans histiocytosis. If you remember, also in melanoma, we have a similar mutation. What about a little about the background and epidemiology? The first case of Langerhans histiocytosis was described by Alfred Hunt in 1893 in a patient, a 3 years old patient, a child with polyuria, ophthalmos, and hepatosplenomegaly. Then Henry Christian and Arthur Schuller reported a similar cases. Then the disease was called in 1893 as Hans-Schuller-Christian disease in honor of the doctors. In 1941, Faber described other diseases that were related to multisystemic disorders, and 1953, the latter described disease as eosinophilic granuloma were identified as histiocytosis X. And finally, in 1985, the disease was renamed as Langerhans cell histiocytosis. But this disease mainly affects children under 10 years old. You can see the age distribution of Langerhans cell histiocytosis in the current series of 90 patients. Mostly 70, 80, 85% of the cases are seen in pediatric age. This is the incidence in adults is centered between the third and the fifth decades of life and is very uncommon in the adulthood. This is a general graphic about the proliferation of histiocytosis leading to the formation of tumors. And histiocytosis in general is a varied group of rare disorders, which common denominator is the myeloid cell overgrowth and infiltration of nearly every organ of the human body. It may start at any age, affecting both adults and children. It can also be explained as the proliferation of histiocytes. And in this graphic, the most common is the Erdheim-Chester disease, and then the Langerhans cell histiocytosis, which we're going to center to focus. Traditional classification is this, the eosinophilic granuloma, the letter SY disease, the Hans-Schuller-Christian. I'm not going to enter specifically. We are going to the current classification with unifocal eosinophilic granuloma with single system, single site disease, multifocal eosinophilic granuloma, single system, multiple site disease, acute disseminated histiocytosis, and multisystem disease. And what about the clinical features? Well, the clinical presentation are very varied. It can present as a disease that affects a single organ and remits spontaneously, or as an aggressive multisystem disease that leads to the patient's death. As our patient, each organ of the body can be affected alone or in combination, but the organs most frequently affected are the skin and the bone. And the skin condition manifests itself as nodule, plaques, or seborrheic dermatitis. The median age at diagnosis is from the 3 to 6 years old. Children below the 1 year old often present multiple organ involvement, and about 70 cases of LCH in children involve a single organ system, with bone being the main site. Here we can see that the 30% belongs to the skin, especially in scalp, intertriginous areas, bone, children and adults. They produce risk of injury to the spinal cord. The lesion produces a punched out appearance, very similar to the multiple myeloma. And when affects to the central nervous system in the face of the skull can cause hypothalamic nuclear affection and insipid diabetes and cerebellum affection. And other organs as well affected are soft tissue, lymph nodes, spleen, liver, and lungs. And well, talking about the focusly in adulthood, the multiple phases of Langerhans cell histiocytosis as a single nodule papule in the center of the face, persistent seborrheic dermatitis, papules that remain seborrheic dermatitis, extrafacial rosacea. This patient also had lesions in the ear and in retroauricular area, had lesions in the centrofacial area and had exophthalmos. Also had nest-like ulcers and bilateral groin. Here we can see extensive quality scally encrusted papules. They can be ulcerated. And under the breast, intertriginous areas, intermammary, mimicking candidosis, lymph lesions, and a man with perifollicular Langerhans cells histiocytosis in the face. This is the diagnosis algorithm. It's based on histological and immunophenotypic examination. So first, we need the complete patient story, including a smoking story, and specific physical examination should be carried out, including neurologic evaluation of the central nervous system and peripheral nerves. In certain situations, such as vertebra or tissues near sensory organ, the systemic therapy is recommended, and involvement in craniofacial bones, eyes, ear, and oral cavity. And the diagnosis, the biopsy of lesional tissue and molecular analysis is for mandatory and level evidence A. In the absence of enough tissue, peripheral blood cell-free DNA analysis to evaluate the BRAF mutation, which is the main mutation derived by the MAPK pathway, is an evidence level A. In the pathology, we can see granulomatous histologic lesion containing histiocytes, measure eosinophils, and lymphocytes, neutrophils, the giant cells, and plasma cells. You can see necrosis, xanthomatous changes, and fibrosis may occur. This is a cytology smear where we can see many histiocytes with irregular and reniform pale nuclei, some eosinophils. Some authors call the coffee bean nuclei typical of this disease, the coffee bean nuclei, as we can see. The immunochemistry test. This is very important. The histiocytosis show nuclear and cytoplasmic staining for S100. The CD1A immunoreactivity in the cell membrane staining, and the langerhans. The langerhans is the CD207, the cell membrane and the Golgi in a granular pattern. Historically, the racquetoid or beer-red granules, which had rod-shaped organelles with a central striation terminal vesicular dilatation like a tennis racket appearance. But the confirmation of cytoplasmic beer-red granules by electron microscopy is now no longer necessary for the diagnosis. With a PET scan, which define the disease of extent, is evidence level 3. MRI with gadolinium in cases with suspect pituitary dysfunction or neurological symptoms. A high-resolution tomography in cases of lung disease, bronchoscopy biopsy to confirm the diagnosis, and ERCP in cases with cholestasis markers, sclerosing cholangitis, and bone marrow biopsy. What about dermoscopic features? Well, clinically, here we see multiple skin color to erythematous papules over the scalp with greasy scalp. And at the dermoscope on the scalp, papule showing irregular vascular blotches around structureless area and crust. In the case number 2, multiple hypopigmented papules with few having central umbilication. And in the dermoscope examination of the umbilical papule showing a central brown dot structureless area surrounded by the white structureless area. At the end, in the third picture, we can see hypopigment papules showing diffuse white structureless area here. You can see. This is another case, the clinical image for langerhans cell histiocytosis with multiple erythromatous papules on abdominal papules, and at the dermoscope image, we can see reddish purple areas in a geographic pattern and brown dots. In this study, the sites of predilection include the trunk and extremities. The most common dermoscopic pattern was the erythematous scaly rash. Here we can see some clinical manifestation, multiple erythematous plaques, 3 to 7 millimeters in diameter with ulcer on the labia majora, vulva. In the second picture, petechias with purple streak. And here we can see reflectance confocal microscopy with show the focal highly reflective dense images on the surface, epidermis with architectural disarray, obscuration of dermoepidermal junction, and numerous polygonal and large medium reflective short dendritic cells in the epidermis and dermis. And well, about the therapeutic approach for multifocal issues, bisphosphonates or systemic chemotherapy for multifocal cutaneous, topical therapy, low dose weekly methotrexate and prednisone. And for multisystemic langerhans histiocytosis, extensive or refractory multifocal single system, agents like cladribine, cytarabine, or vinblastine and prednisone, or patient is in this classification. For LCH involved brain parenchyma, the first line of chemotherapy with cladribine, cytarabine is recommended, and refractory first line for within organ dysfunction, alternate conventional treatment or targeted therapies to the BRAF and MAK inhibitors should be implemented. About the prognosis for LCH depends on the degree of organic involvement and the response to treatment. In most cases, excellent. Unifocal bone disease tends to complete resolution. But the most important here is if an organ is involved, which organ is involved, and how many organs are involved. And the age. Younger than 2 years, they are being a liability. A risk on organ involvement is the hematopoietic system, the spleen, liver, and lungs. And central nervous system are lesion risk. Those involve the craniofacial bones, the insipid diabetes. The follow-up testing is essential to identify patients who may develop progressive disease, to detect the long-term effects and therapies. And finally, highlights to a message to take home. Langerhans cells histiocytosis should be kept in mind in patients with severe and persistent seborrheic dermatitis with or without alopecia. When you are approaching a patient with cicatricial alopecia, you should keep in mind that this is another nosological entity in the scarring alopecia. The biopsy will give so much information, and I suggest that histologic diagnosis be done by expertise dermatopathologist. The LCH can mimic other inflammatory infections and neoplastic conditions. It's the great pretender, remember? And trichoscopic fissures described in the LCH is widespread red-blue lections of different size, central white area with peripheral telangiectasia, presence of reddish purple areas and brown dots may help in distinguish the LCH from another dermatosis. And thank you very much. I'm to your orders. Thank you.